Everyone, welcome back. Today we're diving deep into pulmonary arterial hypertension, or PAH. Not just the basics, but what you need to know at the fellow level to treat this like a pro. We'll walk through the clinical classification, diagnostic pearls, advanced hemodynamics, and evolving therapies, especially the implications of recent trials like Stellar and the role of agents like sotatercept. So let's go. So what is PAH? PAH is classified as Group 1 pulmonary hypertension in the WHO system. It's a free capillary disease of small pulmonary arterioles characterized by vascular remodeling, medial hypertrophy, intimal fibrosis, and plexiform lesions. It's not the same as pulmonary hypertension or just PH that comes from the left heart or chronic lung disease. In PAH, the wedge pressure is normal, and that's a crucial distinguishing point. So who gets PAH? In fact, it's pretty rare, but it's high risk. Idiopathic PAH is the classic form, but it's also associated with connective tissue diseases like systemic sclerosis. There's also been association with HIV, portal hypertension, congenital heart failure, and also drugs like amphetamines and dasatinib. Remember BMPR2 mutations? About 75% of heritable cases carry it. Um, Think about this in younger patients or those with family history. This is also seen in first aid. They sometimes mention it. The MBMEs or step two sometimes use this as an answer choice. So, what's the diagnosis? Essentially, the cornerstone of diagnosis is right heart catheterization. Don't skip this. Echo can't confirm PAH. What you're looking for is an NPAP greater than or equal to 20, a PAWP less than or equal to 15, or a PVR greater than or equal to 3 Woods units. Also assess for vasoreactivity. Use inhaled nitric oxide or IV epoprostenol during the cath. Only a small subset, often idiopathic, actually respond to calcium channel blockers long term. Workup usually includes an ANA, HIV test, LFTs, TSH, get a VQ scan to rule out CT, PH, uh, get a high res CT of ILDs in the picture. So this is also important because you need to be able to interpret right heart cath hemodynamics. On right heart cath, it's all about interpreting numbers. RA pressure high suggests RV failure. PVR elevated, this actually confirms precapillary process. If PAWP is over 15, pause. It could be either group 2 or a mixed picture. And don't forget cardiac index. A CI less than 2.0 liters per minute, that's actually correlated with a poor prognosis. So for the actual management, it's risk stratified and goal directed. So the key classes include endothelin receptor antagonists like bosentan or ambrisentan, PD5 inhibitors, sildenafil, tadalafil, prostacyclin analogs like epoprostenol IV, also known as Velitree. That's what we use here at our ICU the most. Treprostinil SC or inhaled, and of course there's some guanylate cyclase stimulators like riociguat. You'll typically start oral therapy with 2 of these drugs in most patients, like ambrisentan and tadalafil. High-risk patients, especially those with syncope, low CA, or WHO class 4, need upfront triple therapy, including the IV prostacyclins. And here's for the game changer I was telling you guys about. Sotatercept is an activin signaling inhibitor. This actually showed major benefit in the Stellar trial. It improved 6-MWD, reduced PVR, and improved WHO class. FDA approved in 2024, likely to become a major tool, especially in high risk patients not tolerating parentals. PAH is aggressive, but targeted therapies, close follow up, and structured risk assessment can change lives. Always remember to re stratify every few months. Don't delay referral for lung transplant if your patient's not improving. If you found this helpful, drop a like, hit subscribe, and leave a comment below with any topics covered in the future. I'm just starting my YouTube channel. I'm still learning how to make YouTube videos. I'm doing this in between calls in the fellow room. And I really just want to use this platform to further I don't know, the mystery and interest in critical care, both on the medicine side as well as the surgical side. Alrighty. Until next time, keep healing smarter. Thank you.